Hi everyone. I want to do a little lecture on the fluid and fluid movement in the body. This mini lecture content begins on slide 54 of your student handout for this section, and you can take notes from there and follow right along. So when we look at fluids in the body, what you're really checking out is how much fluid, where it's at, because there's a lot of different compartments in the body and it can move between those compartments. And we also have to consider gender, because men have less or a lower ratio of fat to skeletal muscle, and so they have a lower body water content. Skeletal muscle holds most of the fluid, and we know that infants have a higher percentage of body water stored in interstitial spaces, and older adults begin to lose skeletal muscle as they lose fat, or their fat content changes, and then it just continues to decrease from there for other reasons that we'll talk about as we move forward in other content lectures. So because fluids vary depending on gender and age, you need to take those into consideration. Definitely infants and older adults are at higher risk for fluid problems due to those changes. We have three main types of fluids that I might administer to someone who's sick. They are isotonic, hypotonic, and hypertonic. Now what's kind of neat is that the isotonic solution is the same solute concentration. So when we're talking about solutes, what we're talking about basically is the number of different chemicals or other solids that are in the fluid. So let's say, for example, these red dots are sodium, and on the other side of this semi-permeable membrane are these dots, and these are potassium. In a isotonic solution, there's the exact same number of solute concentration on one side as the other, so there's no fluid movement, it's just the same. If there's a hypotonic solution, then there's a lower concentration on one side than the other, and a hypertonic solution has a higher concentration than another solution. So on this side, this is a lower concentration. I really am horrible about writing. And this one is higher with my mouse. It's just horrible. I can't do it very well. And we're always going to be referring to a semi-permeable membrane that is in between. Now this could be the cell wall. It could be any cell wall. So you got to kind of think abstractly. Oh, here's another example of this concentration of fluid. So if I have a isotonic solution where the concentration of fluid is nearly equal to the concentration of the sodium in the blood, then if you put the two fluids next to each other with that semi-permeable membrane between them, the concentration is almost identical on either side, so we don't have any net shifts that occur. So the amount of water that moves into the cell is the same as the amount of water that moves out of the cell. They're equal. However, if we have a hypertonic solution, we'll find that the concentration of fluid containing sodium is higher than the amount of sodium in the blood. And that means here we see that we have more water going into the cell. So the concentration of sodium, when it's higher outside of the cell, the water shifts into the cell. and it keeps bringing water in until either they equal, the inside and outside become equal, or the cells eventually burst. Um, the intent in medicine is not that the cells burst, it's to equalize the situation. In hypertonic, the concentration of fluid is lower than the concentration in the blood. And so if you have these cells separated, the concentration being lower, the water is going to move out of the cell, and so the cells shrink. So water moves out of the cell membrane and the cells shrink. So if you see that all together, if you have hypertonic, the cells are going to shrink. If it's hypotonic, the cells are going to expand. And if it's isotonic, everyone's happy and perfect. We would give a hypotonic solution to someone who was dehydrated and we needed to kind of boost them up a little bit. We might give a hypertonic solution to, a good example of this is when people do sinus flushes where they use a hypertonic solution and they'll flush out their sinus cavities. It gets rid of dirt and bacteria and dust, but it also makes the tissues shrink so they don't have as much swelling. And that allows people to breathe a little bit more easily. And then isotonic is, like we said, everybody's happy. So I want to give someone some fluids. I want to give them just enough to keep them balanced, but I'm not going to take away fluids from cells or expand those cells either way. So here's another diagram. If we have a concentrated salt or sugar solution and a solution of distilled water, and we put an egg, a whole egg, shell and all, in each of these solutions. You guys could do this at home. The egg in the solution with the concentration of salt or sugar is shrinking, while the egg in the distilled water will get larger. And why don't you think about that for a little bit? I'd like to have you just take a minute or two and consider that and shoot me a message. You can do that in the discussion area where the general questions are, or send it to me via email and discuss the reasons why this egg changes, what's happening to the water and to the solutes. So fluids, basically, we know that fluids and nutrients, they're constantly moving and shifting within the body and the body's compartments. All of these shifts have implications for our patients who have illnesses. So every single IV fluid that we give a patient is classified as either isotonic, hypotonic, or hypertonic. They're definitely given to help a patient's condition. We're going to continue to talk about that as we move forward. Physicians will order a certain type of IV fluid. What the nurse needs to do is make sure that that's appropriate for the patient's condition, and if it isn't, clarify with the physician and then administer that fluid. Everything you do to your patient, if you question it or don't understand, you want to talk to the physician and get either clarify your understanding so that you know why we're doing it, or administer that medication as it's ordered. If since we're the last checkpoint before something happens to the patient, it's important that nurses understand why we are doing something, administering something, and ensure that it's an appropriate course of action. So we've kind of talked about all of these things that are on here, not quite all of them yet, but the semi-permeable membrane for sure. So we want to know how fluids move, right? And we know that we drink a lot of fluids in order to get fluids in our body. And we should have a certain amount of fluids that are in our body. The semi-permeable membrane are those membranes that are around blood vessels and cells, and certainly fluids and solutes are able to pass through those membranes, depending on the size, and others are not. We get our fluid to all parts of our body through both our blood vessels and our GI tract, and we definitely use fluids in our brain, in our stomach, in our intestines, in our joints. It's everywhere. We really need to have it present. We can do a couple of different things in order to have our body actually move solutes. The first one we've really talked about already. It's actually at the bottom of your slide. It's called diffusion. And diffusion is just when solutes move from an area of higher concentration to one of a lower concentration. No energy is required. Passive transport is how this happens. It just happens because of the concentration change. And that's what we really were talking about in the previous slides. But we can also have a process that's called active transport. And that's when solutes move from an area of lower concentration to an area of higher concentration. And this requires some type of energy. Usually, not in all cases, but typically, we use adenine triphosphate, or ATP, and that's the energy that allows us to do that function. ATP supplies energy for solute movement in and out of cells, and one of the great examples of this is the sodium-potassium pump. If you feel like you need to review how that sodium-potassium pump works, please do so. Or anything about the ATP and how that active transport works. You'll find that there's quite a bit of information from anatomy and physiology that we expect you to already have. So anytime you question something you're not quite sure, go back and review those concepts, okay? So we're going to talk about each of these in a little bit more detail. Diffusion is a substance that is a process that moves a substance from a region of higher concentration to one of low concentration, and it does it without any required energy. So if we start with a semi-permeable membrane and fluids on either side of that, you're going to see up here in this first image more solutes on top than there are below. And as diffusion works, these solutes are going to move through the semi-permeable membrane so that we end up with closer to an equivalence between the two sides. The goal of all of our systems is to become balanced or have an equilibrium. And so the whole system is always striving to have equal solutes on each part. So the molecules kind of squeeze through. They'd certainly have to be small in order to do that. And some molecules that are certain sizes won't be able to move through. There we go. So if two solutions of different concentration are separated by a semi-permeable membrane, which is permeable to the smaller solvent molecules but not bigger ones, then the solvent will tend to diffuse across the membrane from the less concentrated to the more concentrated. So this is a type of movement that's called osmosis, and it's a special type of diffusion where the movement across that semi-permeable membrane moves from high to low concentration. And that's because of the solutes and the size of some of the solutes. So as that solute concentration increases, the free water concentration then decreases. And then make sure you understand that hypertonic and hypotonic terms. So osmosis is a special type of diffusion where movement of water moves from an area of high concentration to an area of lower concentration. Frequently this happens because of different or differing size molecules that are on either side of the semipermeable membrane, where some of those molecules can move and some of them cannot. We also need to think about how fluid moves through capillaries, because capillaries are very tiny vessels, and because they're smaller, fluids and solutes move differently. So there's always a difference or net difference between how those fluids move, and we call that hydrostatic and colloid osmotic pressures. These are important concepts for you to know through the entire course and your nursing career. Hydrostatic pressure is that pressure that's exerted by fluid at equilibrium. So at equilibrium means we have the same number of molecules on each side of the semipermeable membrane. Due to gravity, hydrostatic pressure increases in proportion to the depth measured from the surface because of a increasing weight of fluid exerting a downward force from above. So hydrostatic pressure deals with gravity. That gravity is pushing down. That's the force from above. And hydrostatic pressure is measured from the surface based on that gravity force. Colloid osmotic pressure is another form of osmotic pressure. This is induced by proteins, usually albumin, in the blood vessel's plasma, and that displaces water molecules. So the albumin pushes the water molecules out of the way, and that creates a water molecule deficit, where the water molecules move back into the circulatory system within the lower pressure venous end of capillaries. This is also called oncotic pressure. So if you have a vessel, and then down here we have little capillaries, they're a lot smaller than the vessel. They're going to our fingers, to our toes, to the ends. The oncotic pressure, the colloid oncotic osmotic pressure, is exerted on these tiny capillaries, and it makes the water molecules move back into the circulatory system. Our kidneys also play a very key role in moving fluids. That kind of makes sense, doesn't it? It's how our kidneys pull the waste products out of our blood and make a fluid that we void out of our bodies or eliminate out of our bodies via urine. There is a capillary blood pressure force that forces the fluid through the capillary walls and into the Bowman's capsule, and that's at the proximal end of the tubule of the kidney. Along the length of that tubule, water and electrolytes are either excreted or retained. So we have our kidney, and then we get a nice ureter that goes down to the bladder, right? Whoops, I'm not a very good drawer. Please remember that. I'm horrible, actually. And then there's our bladder. Well, the Bowman's capsule is inside the kidney. We've got all these little spaces in the kidney, and the Bowman's capsule are even smaller than those spaces. But the capillary blood pressure forces the fluid through the capillary walls and into the Bowman's capsule at that proximal end of the tubule. Along the length of the tubule, so if we say this is our tubule, I'm going to just make it pretty big here. Along the length of the tubule, we'll have water and electrolytes that are either excreted or retained. So water is H2O, right? And electrolytes, we're talking about potassium, we're talking about sodium, and we'll mention others as we move through our content. Those are our big helpers with water movement, though, sodium and potassium. The kidneys will help conserve water if we've lost an extra, even just 1% of total water. So let's say I've been sick and I've had diarrhea for 3 days, so I'm losing extra water because the diarrhea has more fluid attached to it, and I'm eliminating that fluid in a way I don't normally. And so the kidneys are going to say, oh, we need more water. And we're going to hold on to extra water in the length of the tubule. And we're going to keep that water in the body. That makes the urine a darker yellow in color because it's more concentrated. The kidneys have to maintain at least 20 to 30 mLs of urine an hour in order to maintain healthy body functions. If it drops below that, then we can have kidney damage. If I drink extra fluids because I'm really working hard to get my, 8 to 10 glasses of water in a day, my urine will be more dilute or a more pale color, and I have more water that leaves my body, but the body will conserve the electrolytes that it needs. So the urine becomes a lighter shade of yellow. Now, you might have thought you might never have to deal with antidiuretic hormone again. Unfortunately, that's not the case, and we'll come back to antidiuretic hormone all the way through the term, unfortunately. We'll refer to antidiuretic hormone with the abbreviation ADH. If I'm given a test question, I usually put both, antidiuretic hormone, just like this heading, parentheses, ADH. Some of those key components you need to remember about ADH is that ADH helps retain water in our bodies, and it's also called vasopressin. We produce ADH in the hypothalamus, but the pituitary gland actually stores and releases ADH. Here's a video if you want to learn more about ADH and those basic functions. We can inhibit the release of ADH, or we can release more ADH. If we inhibit the release, then that actually occurs if we have a decreased serum osmolality or an increased blood volume. The opposite, a release of ADH, is initiated when we have an increased serum osmolality or a decreased blood volume. The renin-angiotensin-aldosterone system, or RAAS, is another system that our bodies use to help balance water and electrolytes in the body. There are certain cells in the kidney called juxtaglomerular cells. These are near each of the glomerulus, and they secrete an enzyme called renin. There's several steps that result in renin producing angiotensin II, which is a potent vasoconstrictor. So to constrict or vasoconstrict, what that means is if we have a blood vessel that looks like this, if we constrict that blood vessel, the blood vessel is going to look like this, and we're going to have a smaller blood vessel, and that renin helps to make that happen. Angiotensin II also causes peripheral vasoconstriction, and it will stimulate the production of aldosterone. Both actions, when we have a constricted blood vessel and the production of aldosterone, causes the blood pressure to rise. So our body has multiple built-in mechanisms to keep our blood pressure at a certain rate. we don't want it too high, but we also don't want it too low. And since we have to have blood moving through our kidneys at a rate that's appropriate to produce 20 to 30 mLs of urine an hour, we need our blood pressure at a certain level. When the blood pressure returns to normal, the body stops producing renin, and we move back to the normal state of our blood vessels. So we also know that the amount of renin that's secreted depends on blood flow and the level of sodium in the blood. So renin depends on blood flow and the level of sodium. If the blood flow to the kidney slows, the amount of sodium that reaches the glomerulus drops, and then those juxtaglomerular cells secrete more renin. But the opposite is also true. So aldosterone also helps, just like I mentioned on the previous slide. And when our blood volume drops, the aldosterone begins an active transport process with sodium. And as more sodium is forced into the bloodstream, more water is reabsorbed. And so our blood volume expands and our blood pressure comes up. I think there's a lot of ways to help remember this, and I try to use some images and diagrams, at least in a simplified fashion, to help you remember. So if it helps you to draw them out, use one of these diagrams like this. If it is better for you to write it out in words, then do that. Whatever's going to help you remember what's happening. So if our renin is increased, we're going to have more angiotensin 2 or 1 and 2, and that's going to increase our aldosterone. If we have more tubular sodium resorption and decrease sodium excretion, then we're going to have an increased urine output. And then the opposite is true on this side, a decreased urine output. Atrial natriuretic peptide, or ANP, is also another role that influences fluid and electrolyte balance. This is a cardiac hormone, and it's stored in the cells of the atria of the heart, and it's released when the atrial pressure increases. The ANP actually counteracts the effects of the RAS system by decreasing blood pressure and decreasing intravascular blood volume. So if we have an extra atrial stretching, that can lead to increases in the amount of ANP released. So if our patient has atrial tachycardia or a high sodium intake, drugs that cause vasodilation, or their blood pressure drops, all of these things will increase the amount of ANP that's released, and our blood pressure will drop. So it results in a dropped blood pressure. The most simple mechanism for fluid balance is actually thirst. Thirst is stimulated when there's even small losses of fluids, like eating a couple salty potato chips. In older persons, this is less effective, and in some individuals, it's not effective enough to make major changes in blood pressure or water movement. Thirst is usually a later sign, and by the time you're thirsty, or you recognize that you're thirsty, you're behind on water already. So in review, when you think about the body's organs and which organs have an impact on balancing fluids, we have quite a few that impact fluid balance. We've talked about the kidney, and we've talked about the cells in blood vessels, and we've talked about the heart, also the GI tract. And so there's a lot of different ways that we can see that the different major organs work together to help balance fluids. There's a couple of different types of fluid losses. One of those is called insensible, and that's not able to be measured. So how much a person sweats, how much fluids are lost when when we defecate or when we're breathing. Some of our fluids are lost in those situations. Sensible fluid losses are more measurable. So, for example, I can measure how much I drink based on a cup size. If I have a coffee cup, or whether it's a 20-ounce glass of soda, or if it is some other way to actually measure. I could measure my urine output by using a graduated cylinder, and you'll learn more about these when you get to nursing fundamentals, but there's markings on these, and yes, we do measure urine output when we need to. We can also measure things like emesis or vomiting, how much is actually there. We can measure diarrhea because it's liquid. We can't measure solid stool, of course. But we can measure these both intake and output or losses. It's important that you know what the fluid types are and that you understand how they work in the body's systems. And then two main fluid compartments that are included in your student handout, but that we didn't really talk about in detail. ICF, or intracellular fluid, is the fluid inside the cell, and it needs to be balanced with the ECF. The ECF is the extracellular fluid, or the fluid outside the cell. And again, it must be balanced with the ICF. And our bodies will always strive to reach that balance. Be sure you know how diffusion, osmosis, active transport, and capillary filtration work. Review how the kidney helps with fluid balance, how our hormones help, and how our thirst mechanism helps. So let's take a look at a couple of questions and answers to those questions. If a nurse is admitting a patient who's been vomiting and had diarrhea for the last 3 days, the nurse knows that based on the patient's symptoms, the amount of ADH secreted would most likely. So if they're losing lots of fluid through vomiting and diarrhea, what happens to the ADH when we're losing fluids? Does it increase, decrease, or stay the same, or not be affected? So we'll actually see an increase. The patient is dehydrated or has too little water on board. So as a result, the body would try to retain as much fluid as possible. And in order for the body to do that, the ADH secretion is going to increase. A 70-year-old male comes to the ER after mowing the grass in the hot sun and feels lightheaded. His blood pressure is 80/40. The nurse knows that the kidneys will respond by secreting renin, producing aldosterone, slowing the release of ADH, or secreting ANP. Now, first you need to know the kidneys respond. So which of these functions does the kidneys, or is the kidneys responsible for? And if you can cross any of those out, that's what I recommend you do first. Cross out the ones that absolutely the kidneys aren't doing, and then see what's left. So the kidneys do secrete renin. Remember, that happens in the juxtaglomerular cells in the kidney, and they secrete renin in response to low blood flow or a low sodium level. If the blood pressure is low, our patient has low blood flow. That's where you need to make that jump to know that low blood pressure equals low blood flow. And then the final effect of renin secretion is to increase the blood pressure. All right, so that's the end of this slide. Do review this. Let me know if you have questions. I'd love to hear from you.